Let's get started. We got some great papers on this session. The first presenter is Dr. Ko and colleagues from Emory University School of Medicine, and the title of their presentation is Stent Graft Oversizing is Associated with Increased Risk of Long-Term Ventricular Wall Thickening in Young Patients Following TEVAR.
Good afternoon. I'd first like to thank the Vascular and Endovascular Surgery Society for the opportunity to present our data. My name is Marissa. I'm a fourth-year medical student at Emory University, and I will be presenting our abstract entitled Stent Graft Oversizing is Associated with Increased Risk of Long-Term Left Ventricular Wall Thickening in Young Patients Following TEVAR. I have nothing to disclose. Several small studies have demonstrated increased LV mass index and LV wall thickening following TEVAR. No studies to date have examined the risk factors for this remodeling. However, some do report associated clinical consequences, including an increase in blood pressure, as well as LV stroke work. Prior investigations have posited that increased LV mass occurs secondary to increased systemic afterload in accordance with Poissier's law and reduced stent graft compliance compared to the compliance of the native aorta. The long-term consequences of remodeling following TEVAR are arguably of greater relevance in younger patients who will be susceptible to these hemodynamic changes for longer periods of time. We hypothesize that the risk of ventricular hypertrophy is predictable following TEVAR, that there are predictive risk factors that predispose to future LV wall thickening. We performed a retrospective chart review of a multi-center hospital system. All individuals under the age of 60 who underwent TEVAR between July of 2011 and July of 2019 with available baseline or preoperative and at least 1 year follow-up contrast CT imaging were included. Standard patient and case demographics were collected, including graft specifications. Measurements were completed by hand using offline contrast CT imaging, including posterior LV wall thickness, as well as native aortic diameter at the proximal landing zone. Graft oversizing was calculated by dividing graft diameter by native aortic diameter at the equivalent proximal landing zone on preoperative imaging. The primary outcome was annual rate of posterior LV wall thickening. Left ventricular hypertrophy was defined according to previously published reports identifying the upper limit of normal posterior LV wall thickness as 11 millimeters in men and 10 millimeters in women. On to results. This is a busy slide. I just want to draw your attention to a few things. 101 patients met inclusion criteria, and average age on date of surgery was 45. For the most part, most variables are not statistically significantly associated with the development of LVH, with the exception of former smoking and African American race or ethnicity. Variables of particular interest are the fact that individuals with prior diagnoses of hypertension were not associated, nor was the indication for initial repair or graft manufacturer. Mean follow-up time was approximately 3.5 years. Mean annual rate of LV wall thickening was approximately 0.5 millimeter per year. Univariate and multivariate linear regression was performed with the annual rate of LV wall thickening as the dependent variable. Both narrower graft diameter and higher percent oversizing were significantly associated with higher rates of LV wall thickening in the univariate analysis. However, only narrower graft diameter remained significant in the multivariate analysis. Logistic regression was performed with individuals who met criteria for LVH on CT versus those who did not. The definition of LVH on CT is quoted in the literature and, as mentioned earlier, is greater than 11 millimeters for men and 10 millimeters for women. 43 patients met criteria for LVH at follow-up. These individuals were significantly more likely to have had smaller diameter grafts placed with higher percent stent graft oversizing versus those who did not develop LVH. In summary, in this study, including patients under the age of 60 who underwent TEVAR, those who had smaller diameter grafts placed or those who had higher rates of graft oversizing were more likely to experience higher rates of posterior LV wall thickening or more likely to develop left ventricular hypertrophy. Introduction of endoprosthetic stent grafts, regardless of the material used, not only failed to match perfectly the desensibility and compliance of the aorta, but also fundamentally changed the molecular structure and biomechanical properties of native vessel walls. Animal models have demonstrated fewer elastic and muscle fibers within the aortic wall correlated with rate of stent graft oversizing, as well as reductions in maximum shear strength, stress, and tension supported by the aortic wall following placement of stent grafts. In addition, reductions in desensibility and compliance of the aorta secondary to stent graft mechanics could contribute to increased systemic afterload, resulting in maladaptive cardiovascular remodeling commonly observed in situations of longstanding hypertension. A significant number of patients in this study had pre-existing diagnoses of hypertension. However, we found no significant association between pre-existing diagnosis of hypertension and rate of posterior LV wall thickening or the development of LVH. Prior investigations have noted reduced exercise tolerance, and increased blood pressure associated with LV wall thickening following TEVAR. For the sake of time, I've not shown the data here, but I'll note that while this study was neither powered nor designed to examine the clinical consequences of cardiovascular remodeling, we did not find any significant association between rate of posterior LV wall thickening or the development of LVH with any relevant clinical consequences. This study has several limitations. However, the most significant is arguably the use of CT imaging to determine measurements. Ideally, we would have had echocardiographic images available to us from which to measure preload independent variables. Echo is a more widely recognized imaging modality used to make these kinds of measurements. However, few to no patients had any echo imaging done, so we chose to use what was available to us. It is worth noting, however, that there is a good amount of pre-existing data around using CT for cross-sectional measurements of cardiac structures and the correlation between CT and echo. Future studies should continue to follow these patients to 10 or 20 years postoperatively to further characterize these changes and their risk factors. More research into stent graft technologies that closely match the desensibility and compliance of the native aorta should be performed, including the role bioabsorbable grafts may play in the future. In addition, the impact of pharmacologic agents, especially ACE inhibitors and ARBs, already known to combat cardiovascular remodeling in the setting of chronic hypertension, should be examined to determine their ability to modify these rates of remodeling. In conclusion, this study demonstrates that due to the identified association between long-term LV wall thickening following TEVAR and stent graft oversizing, the decision made to oversize and to what degree to oversize stent grafts should be made with consideration of these long-term effects, especially in patients with smaller aortic diameters. Long-term maladaptive cardiovascular remodeling has the potential to cause issues many years down the line, especially in younger patients. For those with smaller aortic diameters, consideration of open repair may be necessary. Thank you very much for your attention. I'd like to thank the programming committee again for the opportunity to present our data and to Dr. Rajani for his mentorship and guidance. I will be happy to address any questions that may have arisen during the presentation.
Okay. So we've got some good questions. Congrats on a great presentation. First question is from Dr. Gregory McGee. Did you look at graft oversizing only at the proximal seal zone or also distally? Wondering if tapered stents would make a difference.
So we only looked at oversizing at the proximal landing zone. We did, however, include tapered grafts in the univariate and multivariate analyses, and there did not appear to be an association between presence or absence of tapered graft and rate of left ventricular wall thickening.
Okay. And don't get nervous, but I've got a question from President-elect Jason Lee. Do you have a control population of patients with similar comorbidities to know if the findings are from the TEVAR device or just aortic disease and hypertension? Good question.
So we did not specifically, propensity match with the control population. So the question of whether or not left ventricular remodeling is due to pre-existing hypertension, I think is still outstanding. We did, however, include whether or not patients had pre-existing diagnoses of hypertension in our analysis, and there did not appear to be an association.
Next question is from Dr. Mark Conrad. It looks like 50% of your patients were treated for dissection. Did aortic pathology predict left ventricular hypertrophy?
So we did include indication of dissection, aneurysm, transection, and then penetrating aortic ulcer and intramural hematoma. And none of those were significantly associated independently with left ventricular wall thickening.
Another question here from Dr. Jeannie Ruddy. Hi, very interesting question. Sorry if I missed this, but can you elaborate on the threshold of oversizing that led to LVH? I think she's asking if there was a cut point that predicted LVH.
So there was no cut point. I will say, just if you average the percent oversizing as we calculated in the group, overall, all 200 some patients, it was 13.3%. And in the population that developed LVH, it was 15.1%. I don't know if that answers the question.
Okay, and let me ask you one final question. One of the last bullet points you had on there was talking about this could lead to clinical manifestations or signs or symptoms. How many of the patients in this group had actually manifestations of heart failure or other clinically apparent findings that wouldn't have been identified if they hadn't had the CT scan?
Sure. So we looked at, this study was, I think first it's important to say this study was not, powered or designed to look at clinical consequences of the left ventricular remodeling. We did, however, do an analysis that I didn't show the numbers for that looked at the relationship between annual rate of LV wall thickening and whether or not patients met criteria for LVH and new diagnoses of congestive heart failure or hypertension. And there was no significant relationship. So, but I don't think that's to say that, average follow-up time for this population was 3.5 years. So it's not to say that 5 or 10 years down the line, patients could develop clinical consequences from this remodeling.
Well, that was very well presented, and I want to congratulate you on a very interesting analysis. And Dr. Zukow is going to introduce our next speaker.